Really wonderful to have my esteemed colleagues with me here today. One of the strengths I think that we have here, I think we would all agree at Downstate, is the interprofessional nature of our composition as a health sciences university. And we have individuals from across our university with us today to speak about various aspects of an ethics of population health as it relates to their own profession and practice. And I'm really thrilled that we have this opportunity to learn from the interprofessional perspectives available to us here and to leverage the expertise of my colleagues in this conversation. So just to start, I thank you all for being with us today and for taking on the mantle of, a fairly heavy, I recognize heavy charge of, representing a profession which has diverse perspectives, et cetera. So I will only hold you accountable to representing your own. But I think we'll find a lot of opportunity here in leveraging just the different orientations that arise in thinking through questions of ethics as it pertains to public and population health. And we will have some questions that I provided to the panelists in advance, and then I'll have an opportunity for a question and answer session at the end of our talk. So I do encourage folks to think of questions you might have for our panel today as we go through our conversation. And I thought that I would just start by locating us as we're thinking about this particular question of what our respective professions and our practice can provide for insight in thinking about ethics of population health with a definition of what population health is. Often we think of it as the health outcomes of a group of individuals, including the distribution of such outcomes within the group. And I think the question of both the overall population health, but also the distribution comes back to some remarks that Dr. Bayer have been making in thinking about the imperative of public health ethic with respect to both utilitarianism as well as justice. And needing to think about that in the context of our conversation today, I would encourage us to bring those considerations to light, particularly as our shared mission here is so centrally to advance health equity and justice here at Downstate. As I had mentioned, we have a really fabulous set of panelists with us today from across the university. We have our College of Medicine represented with Dr. Booten Foster with us today, so really thrilled to have you. We have Dr. Kaufman with us from the School of Health-Related Professions. Welcome, Dr. Kaufman. We have Dr. Roberts from the College of Nursing. Welcome. And lastly, we have Mr. Versfeld, who comes to us, relatively unusually from our Office of General Counsel. And I think it will be really interesting to have some legal perspectives brought to bear on our conversation today. So thank you for joining us. Just to get us started, I'll just ask that you each introduce yourself more fully, and that was a very quick introduction, and that you offer from your professional lens what you see as key ethical questions that confront our efforts to advance population health. What specific contributions might your specific ethical code within your professional practice have to offer as we think about advancing population health in ways that consider and integrate strong ethical and value in our practice? So, Mr. Versfeld,
go first.
Thank you.
Is this on? Can you hear me okay?
Yeah, thanks.
Yeah. Thank you. So Will Versfeld, again, I'm from the Office of General Counsel here at SUNY Downstate, so I'm technically the interim chief campus counsel for now. We've been blessed to have a few other chief campus counsels. Oh, I'll go closer. Sorry about that. Going back decades, so I'm happy to serve in that role right now. And as Dr. Mackey said, I probably come to this from a bit of a different lens in that I frankly do not focus on population health in my day-to-day, right? I'm happy to go into what I do focus on, but certainly ethics is a big part of that. And so I did want to shout out the previous speakers, Dr. Bayer, Dr. Ayal. I thought both presentations were excellent. I found myself nodding along and thinking especially about, justice. That is something that I do think about and that I do consider in my role. So a little bit of background about what the role is. I head the office. We have 5 attorneys here. Each has a bit of a different specialization. So we have someone who works on contracts, on procurement. We have someone who specializes in labor and employment. We have thousands of employees here. Someone who focuses on the clinical side. Her name is Lauren. She's excellent. If you ever need she's an RN as well. So we have a great team. And basically, what we do is, as lawyers, putting lawyer jokes aside, we really do have a very strong code of ethics that we must abide by. There's a model rules of professional conduct that oversee ethical obligations on behalf of all attorneys nationwide. New York State has adopted a similar code. And basically, as it pertains to, I'd say, this topic most generally, it's a duty of honesty, right? It goes along with the informed consent and, an IRB looking at human challenge trials and whatnot. Attorneys have to be honest, both with their clients directly, and, what we do on a day-to-day basis is advise our clients. Here are the risks. Here are the opportunities if you want to engage in this endeavor. And also our counterparts, right? In a litigation context, you can't lie to a judge, you can't lie to the other side. You have to be upfront, you have to be ethical in that sense. If you don't, you risk debarment, right? And so those obligations are always in the back of our minds in counsel's office. And indeed, it is something you got to think about. We do continuing legal education, just as a lot of you do CMEs, right? And you have to re-register with the bar and stay in good standing. All those things, if you don't use it, you lose it, right? You really got to stay on top of that, and that's an important part of our legal obligations.
Thank you, Will. So hi, everyone. Carla Boutin-Foster. I'm a faculty member in the College of Medicine. I trained at SUNY Downstate. I'm a clinician, internal medicine trained. And currently my role is as leading the Office of Diversity, Diversity, Education, and Research, and the Office for Institutional Equity in the College of Medicine and the institution as a whole. So as a clinician, some of the pillars that we abide by include autonomy, beneficence, non-maleficence, and justice. And those are really integral to equity, because without the ability to enable our patients or to strengthen their ability to truly participate in medical decision-making, then there isn't equity, because we're not able to provide care that will give an opportunity for everyone to achieve their best health if they're not able to fully participate in decision-making. As clinicians and medical educators, we also must constantly weigh what we're doing, balance beneficence versus intentional maleficence, non-maleficence versus beneficence. And in order for us to do that, we must look through an equity lens and really check our own biases, because there are several examples in the literature and in science of clinicians and scientists doing things that they think are, that are done, I think, out of good intentions, but yet, as we heard from our speaker, that they have significant consequences. And then there's justice, and that's an area that we don't often talk about, because we think that, at least traditionally, that's a social science, a public health, a legal matter. But as clinicians, we are really, I think we must also stand on pillars of justice if we are to promote equity and create opportunities for all. So this discussion is very relevant to what we do in the College of Medicine, and actually in all of our schools as health professionals and health educators. And one of the things that I really like about Downstate is that we can have these discussions because we work with each other on a regular basis, and there's this mutual respect for the institution that we can't do this alone. And in order for us to advance equity, that all of our, I guess, the ethical pillars on which we stand must really align toward equity.
Great, thank you, Dr. Boutin-Foster. Dr. Rohr, yeah.
Thank you. My name is Marie-Claire Roberts from the College of Nursing, and I am a bit hesitant to represent the entire body of nursing, and especially in congruence with the conversation today, because nursing spans inpatient and outpatient. And I really would like to proffer today that we're actually the bridge between public health and inpatient care. Because when I receive a patient to the med-surg unit from the emergency room, I'm asking, where did you come from? And I'm already planning, where are you going back to? I need to understand what has impacted and contributed to you being in my inpatient care setting. Nursing, we have our ANA Code of Ethics, the beneficence, non-malfeasance, and justice. One of the primary roles that nurses have, and we teach them and infiltrate them with, is the need to advocate. Again, a bridge. We advocate in the units for them to get the care, to get safe and quality care. And then in the community setting, the CDC hands us some protocol that is evidence-based, but if you don't eat bananas and peanut butter, then we need to find a better solution to your diet, right? And to this end, the nursing profession on a daily, micro level is impaired with moral dilemmas and ethical dilemmas. Whether it's in the inpatient setting where I need to decide, is that patient who's telling me right now they're going to commit suicide, or the patient who's tanking and I know is going to need a code in about 5 seconds flat, where do I go? What do I do? We operationalize the ethical philosophies and values that we as a society think about. We live them and we do them every single day. And a big problem, again, that we encounter in the public health setting is remuneration. As a public health nurse, I get $0. We are not valued in the space of community-based setting unless it is remunerated. If I'm sent into a patient's home to take care of a wound care, I am expected to completely ignore the myriad of pills that are left untaken, the bacon that the patient is putting more salt onto, and I'm supposed to provide the wound care and leave. I know that this is a public health crisis. That is the hypertension, that is the diabetes, and that then is a massive problem. So our values, as we have to operationalize them as nurses, are magnified when they go from inpatient to outpatient.
Thank you. I'm Dave Kaufman. I'm representing the program in health informatics in the School of Health Professions. This has given me a lot of food for thought, and so I came in here with a set of ideas and a set of concerns, and they have grown after seeing Dr. Bayer's and Dr. Ayala's talk. So broadly, my profession and academic discipline is concerned with the development, implementation, evaluation of health information technology. We also work on the data science side of things, and so we want to translate information into usable data, which can further be translated into knowledge and hopefully leading to action. I think Dr. Bayer directly or indirectly made this point rather eloquently, is that any introduction of a potential change can sort of cut either way. So we think of technology as a potential to be a great equalizer. It can mitigate disparities, inequities, but it could also amplify that being surface or exacerbate, actually make things worse. And this is something that we need to be very concerned with. And we don't assume that any of that is on the basis of any malevolent act. In fact, in one subdiscipline, consumer health informatics, we have the explicit goal of reducing disparities. And our funding, our grants are built around those ideas. And we develop technologies, such as for telehealth, for remote monitoring. We are not exclusively responsible for developing those, but we play an important part in that. And it definitely has the potential to make a significant difference, but it might be an unequal balance. And those who have less access to these set of technologies are at a disadvantage. So despite best intentions, we are in fact exacerbating inequities and disparities. I have a list of things, I won't go through all of them, but one is EHR documentation and built-in bias. And as we increasingly leverage that data, for example, in AI, that bias becomes further sustained. And there's a lot of interesting, it's not well understood. For example, just one example, is that this was a study at New York Presbyterian Hospital that blacks and Hispanics had poorer documentation than, so the minority population, their patient profile was more poorly documented. There was less information available, and you know, that's something that needs to be further understood. Other issue is the spread of disinformation, and that goes hand in hand with public trust, and that's a complex issue. And we know that disinformation is spreading at a rapid pace, and it's having a real impact. And it's having a disproportionate impact on populations that are, for example, lower in health literacy and so forth. Actually, two quick other points. One is institutional inequity. So there's a lot of work on health disparities, but you know, institutions are differentially resourced. So we saw that had tremendous impact at Downstate, you know, at the height of the pandemic. So public health agencies, for example, required significant increase in reporting. In fact, the level of public health reporting literally increased by an order of magnitude. And certain institutions were better positioned to do that. They had the technology, they could generate reports effortlessly, while Downstate and other smaller institutions had to do a lot of that work manually. And they had to position staff, including clinical staff, in gathering that data. So that's one example of an institutional inequity. And institutional inequities are tied in significant ways with health disparities. My last point, and I think I've gone on a little bit too long, is around the issue of discontinuity of care. It's something that we're just beginning to study. We're working particularly with stroke patients, and we note that most stroke patients present, I'm simplifying it because there's a lot of complexity in this, but will present to an ER, and you know, they'll be treated, some will be admitted for short periods of time, some longer periods of time, and they're put on a treatment plan, but a very large percentage of them don't show up for follow-up. And that is a puzzling thing, and it's probably true, I'm speculating here, of a lot of other chronic conditions, creating discontinuity. And the issue with strokes is that if you can mitigate, if you can mediate, if you can reduce blood pressure, which is almost a low-hanging fruit, you can significantly reduce the risk of a second stroke, and that's a lost opportunity.
Wonderful, and thank you so much. Those were just really insightful reflections. And you know, as I think about public health, and in particularly my role as chair of health policy and management here at Downstate, I was thinking about how you know, so critical to the ethics of public health, as we've heard today from our speakers, is the consideration of the health of populations and individuals, right? Both, through both practices and policies that facilitate the fair and just distribution of resources, right? So as you were each speaking, I was thinking of various ways within which, you know, in many ways, the mandate of public health is to facilitate, you know, often upstream, right? Thinking through the structural systems and ways that we could facilitate equity and fair distribution of resource in just ways through a variety of different preventative and frankly, secondary and tertiary prevention as well. I mean, we as a practice are thinking about the full trajectory of a disease condition, but we often, I think, also recognize and ways that are so critical, as Dr. Roberts was mentioning, just the need to address not just healthcare, as Dr. Bayer was urging for us, but also the social systems that surround the determinants of health and healthcare. And I was also reflecting that in our ethical code is a real mandate to kind of for protection of the individual and collective rights to health. And so I was thinking of to Will's comments with respect to the need to really think about what folks have as rights. And we are often in public health, I would say, balancing the population and the collective right to health with that of the individual autonomy and rights for the individual to have control over their own health and health care. And so many of our ethical conundrums and the things that we spend time thinking about are trying to balance. And as you were each speaking, I was hearing as well a lot of consideration for the trade-offs, right? That much of our practice is about facilitating a consideration of multiple ethical mandates that sometimes are in conflict or create tension for our practice, and that we have to we fall down, whether implicitly or explicitly, in following through with one set of values. And I was appreciating in our conversations and the earlier talks today, there was also a lot of trade-off, right? Like there was trade-offs at the forefront of our consideration as we think about ethical dilemmas. And so the last thing I'll just say that I think is increasingly important to recognize and respect to public health and our professional ethic is just we just have had a new code of ethic come out from the APHA, and this incorporates a respect for ecologies in a way that prior codes of ethics in public health haven't explicitly recognized in quite the same way. And so I think I would just also offer that a public health ethic also considers the ecology, the environments within which we are located, and is forced to reckon with what the impact of our actions are on the environment and on the climate and the worlds within which we inhabit in multiple ways. So. And I think we began to kind of pick up on this, but I'll just turn to the panelists around, where are the learnings for us to think about how to advance public health and population health from your respective professions? And so just would love to hear thoughts about how your field can offer advancement in our consideration of those debates, those tensions, those challenges that confront advancing population and public health.
I'm happy to take this one first. I think that you hit it directly on the head in terms of balancing between an individual's autonomy and then that of the herd, right? And I use that deliberately because the largest example recently, at least in our line of work in counsel's office, obviously it affected everyone, was COVID. And it was the vaccine mandate, right? My office was really involved in that in terms of its enforcement here on campus. And the enforcement is an important aspect because the Department of Health, in its wisdom, said that healthcare workers have to take this vaccine, right? And then it sort of fell on each institution to make sure that that was followed. As you would imagine, there was a lot of pushback on that. Some people, for various reasons, were skeptical of the vaccine. And I will say, a couple years later now, I think Downstate actually fared pretty well. SUNY, Office of General Counsel writ large, right, across 64 campuses, 29 state ops, 3 academic medical centers. For the most part, Downstate had the fewest hiccups in terms of its enforcement. And I think that was in large part due to Dr. Riley's leadership, where he basically said, hey, if you work in this building, and it is just one big building, you're a healthcare worker. And I was like, well, I don't see patients. Do I have to get it? But I happen to be a huge advocate of vaccines, so I gladly got it. But it was, and it for a long time remained a hot topic among our workforce, right? Because if someone declined to get it for whatever reason, whether it was a philosophical objection or a medical objection, right, we had to make sure that there were pathways where that individual's autonomy could be respected. And of course, I want to be clear, in some cases, they were overridden, right? If you insist on not getting the vaccine and you don't have a legitimate medical reason for it, you can't work here anymore, right? And that's a very difficult conversation to have. I thought we did quite well overall, with the benefit of hindsight, in respecting people and offering sort of compassion when the differing philosophical objections were strong enough that, I'm willing to lose my job or technically be suspended during the pendency of that regulation. And of course, looking back more recently, that regulation from the DOH has been challenged in court, as a lot of people expected it would be. And of course, different courts come down differently on whether it was a legitimate regulation that the DOH tried to implement. But again, not necessarily to compare across campuses, but we had a whole slew of people who, went through the process. It happened to go through the Office of Employee and Labor Relations, right? If you didn't want to get unionized or didn't want to get vaccinated, here's what would happen, right? We had a lot of cases, but we had far fewer cases than our counterparts at Stony Brook and SUNY Upstate in Syracuse. And again, I don't think that's necessarily because we had all the answers, but I think we're clear-eyed about what was necessary and how we could best serve our patient population, because of course there were very legitimate concerns about coverage, right? If you lose 30% of your nurses, like you can't function as a hospital. So it was obviously a very difficult time, and something that my office actually was involved in from a population health standpoint. We had to step up and take a major role there and just try to balance both the enforcement under the law, right? That's what we try to do. We enforce regulations, we enforce the law, but also trying to keep an eye on the various reasons, and some are, very legitimate, why people would not want to abide by that regulation. So that was a very real world example from our perspective in counsel's office.
I think in terms of challenges that confront professional workforces, or specifically as a clinician, for me it would really be going back to the balance of doing good and avoiding harm, and how we conceptualize race. So there's still a lot of practice that's race-based. A lot of the literature will ascribe poor outcomes to one group based on race, and even population health as a study. We look at outcomes, racial, ethnic minorities, minoritized groups versus non-minoritized groups, so this group versus that group, without really understanding or going deep into how these constructs were developed. And then when we don't take the step to do that, we perpetuate racism in the practice of medicine. For instance, EGFR. So the estimation of glomerular filtration rate in renal function, 2022, I believe you were involved in that also. We, with the help of the New York City Department of Health, we were able to effectively remove race from this coefficient. And that's really important, because when we look at race in coefficients, they either underestimate potential risk, and therefore may delay referrals, may delay removal of harmful medications, whether it's aspirin in someone with renal insufficiency, or delay referrals to nephrologists for transplant. When we include race in formulas, vaginal birth after cesarean section, we overestimate risk. And then that leads to more women of color or people of color undergoing C-sections just based on race, and that's often just defined by the provider. And the message that a person who's about to give birth and deciding, they'll say, well, because of the way I think you look, I would recommend this. And this is what the science shows. So it's manipulating science in a way that perpetuates disparities. Pulmonary function test, really underestimating risk because of this misconception of bodies. And I think as a profession, we really have to take a look at how these algorithms and were developed. If we think about spirometry, it was developed, it was the values that we use in spirometry and is based on the assumption that Blacks' lungs were inferior. And the solution was work, when you think about that. And then we use that misconceptualization of race, and we carry it forward, and it's used in insurance, it's used in definition of lung function, it's taught to our students, and we make treatments based on that. So the way we think about race and genetics and make decisions and then teach our students who carry this information. There was this article a couple of years ago, students at, I believe it was another academic institution, assumed that there were differences in pain reception and pain fibers just based on one's race, and that led to the likelihood that they would treat. So the science is so important. The science is so important, and if we are to advance science that drives practice and public health, we have to be scientific about it. And race is not genetic. And I say this and I sound like a broken record, but race is not genetic. Race will change. Right? If someone is biracial, what are they? It depends on what the physician is saying. So I think as we advance population health and collect data, we have to make sure that the data is correct. As we advance genomics, we have to make sure that we're not ascribing any type of genetic predisposition based on race. So we talk about sickle cell. Sickle cell is not a race disease. We know it's a genetic mutation, and it's not based on race. So I think that's something that I struggle with as a clinician and now educator, is to get students or learners to think about when they see data and it says this group versus that group, what is it that we're measuring? Because whatever we collect, we measure incorrectly, and then we treat patients or develop clinical algorithms based on this misconception of race. So that's something that we really need to address if we are to advance equity in population health.
Can we ask each other questions? Or do you want to go?
Let's, we'll go through, I just want to make sure
that's
we have
fine.
time for folks
Of
to,
course,
provide. I also am going to ask, I'll just say this now, I'm going to ask Dr. Eyal and Bayer if they would like to give some reflections coming out of this last round of questions, and then we will come to a larger Q&A. So Dr. Roberts? Yeah.
So I think that part of our problems right now are that we're transposing a biomedical disease model which has driven healthcare provision in the inpatient setting and continuing to perpetuate it in the outpatient setting in public health. And I think we have to have very in-depth conversations about that model and those models that we're imposing on the public health setting. Because again, it's what do we value, right? If we value disease, then we will create a structure to impose processes of a certain nature versus if we think about health and well-being. And then going to your point, who decides what health and well-being is? How is that defined? And what does that look like? And again, what are we imposing on a population in terms of the other and as the provider? And so from a nursing perspective, we come from a holistic model. Orem talks about self-care that has nothing to do with providers. It is actually the person in the community setting living with a disease process that has to care for themselves. There's no disease in there. There's no, the traditional model that we see in the inpatient setting. And so I think the conversations are starting to have had, but not enough. And we need to evaluate the outcomes and think about how we measure and evaluate public health in terms of our successes, because that then drives back how we design the structures and the processes and the systems to get those outcomes and to achieve those outcomes. Nurses are not at the table in the way that they should be. If we talk about, and going to the talk that we heard about in terms of challenge trials, just a micro example, a lot of the times the people who are getting informed consent in those trials are nurses. I cannot tell you the number of times that they stand with dilemmas because they're listening to that prospective trial member or participant, and they have to deliver back to the people who designed those trials the reasons why that participant has concerns or might not want to continue in that trial. And we know that if you don't want to continue, you do not have to. But there's such pushback, and the system is so strong, and that advocate is not being heard or listened to. So I think nursing has to do a lot of work in advocating both at the public policy level as well as the public health level in these conversations that we all desperately need to have.
Thanks. I'll pick up on this institutional inequity issue. So broadly, can you hear me? Can you hear me now? Okay. So I'll pick up on the institutional inequity issue. So broadly, our discipline is committed to furthering advances in health information technology. And that's it's quite an exciting time with advances in AI, with the availability of new technologies, with capabilities of decision support that we didn't have previously. And, you know, there's parallel developments. You know, Dr. Boutine Foster talked about genomics and precision medicine and the potential for breakthroughs in treatment of cancer and other diseases. And I think the parallel tells an interesting story because they're not equally available at all institutions. And we have to understand that, and it's not a simple problem that could easily be rectified. But I think it's something we don't understand very well, particularly in relation, I could speak more to information technologies. And I think governmental agencies that create regulations and demands upon different institutions don't understand these sort of differences, and they're significant and they matter, and potentially they impact patient care. So I'm not a health economist, and it's hard for me to get a handle on the full scope of trends in healthcare. For example, the effects of the mergers of hospitals, how New York Presbyterian and Mount Sinai is acquiring other hospitals, and how that's changing the landscape. It clearly is. But you still have smaller independent hospitals. Purchasing power, like the ability to buy a first-class electronic health record system, which costs, I'm speculating here, but upwards of $100 million. So we know that partners spent $2-point-something billion on the healthcare system, on their EHR, which was Epic. And the Mayo Clinic, which has several campuses, spent something comparable to that. So it's not available to everybody. And the distance between the premier electronic health record systems, like Epic and other ones, continue to grow. And it's not only the records, but it's the tools that are available and utilizing them and having the resources, having the staff, and capabilities to do that. And it ripples throughout the system. So you have, for example, not the same decision support capabilities, but also meeting basic public health needs like reporting. Reporting can be a very onerous process, particularly during a pandemic. And we did a study and we documented that. And you know, the magnitude of the challenge was immense. And of course, it's not only uniquely downstate, but it's a problem that I think is not well understood. And I think there needs to be it's not a problem that's easily resolved, of course. It goes well beyond my pay grade. There's a host of, obviously, societal and economic issues. But it's something that we could develop a set of metrics and understand where each institution stands. And is there a minimum level of expectation? Like with electronic health record systems, for example, the Office of the National Coordinator of Health Information Technology has like a 9-point scale. And you're expected to meet, the government regulations, we're expected to meet a certain standard. But we have nothing. There needs to be something broader in scope in relation to health information technology. Where does an institution stand? You know, on basically measuring it, and what is the expectation regarding that? And do public health institutions need to do a set of adjustments on that basis? For example, in requiring reporting, in reporting requirements and so forth. I'm not sure. That last point needs probably some explanation, but I'll leave it at that for the moment.
Great, thanks so much, and really wonderful conversation. I'm going to keep us moving because we are working through our time together today, and I'm just going to ask Dr. Bayer if you might share with us some of your reflections on the panel today.
Thank you. In listening to those of you who deal with patients or are responsible for the care of patients, and as you come to grips with the fact that when you begin to understand the worlds from which your patients come, and when you come to believe that making it possible for them to be healthier will take much more than what you yourself can do in the context of a clinical relationship. So one of the things that's very striking to me is the answers to the social drivers of disease requires us to act as citizens, not as clinicians. You may discover things as clinicians, but recognize the only way in which there will be a solution is a political solution. That means acting as citizens. And I know, people in public health like to say that we do science. We don't want to be politicized. I don't think you can have public health without politics, because the issues involved with the social drivers are political issues that we as a nation, we as a community must address.
Really, I'm reminded of the feminist adage of the personal is political, and thinking through the same in respect to public and population health is political. And so thank you for those remarks.
In a way, I want to pursue the same line. So from my point of view, your hearts are in the right places. I've met over the years, working in medical school environments and in public health school environments, a lot of people whose hearts are in the right place. I've hardly met anybody who says, oh, I'm indifferent to gaps. I only want the average of the population to be high, or I'm indifferent to the average among the population. I only care about the rich. I mean, nobody says that. So why is the situation so bad? Is it, let's put our heads together and figure out what's going on. Is there some collective action problem? We all, as individuals, somehow strive for good, maybe in the clinic, maybe as advocates, but somehow it doesn't happen. Is it that I don't meet the influential people who are, their hearts are in a very different place? I tend to think it's more the former. I mean, yes, there is some selection bias, right? I wouldn't have worked for Liberty University or whatever. But still, there is something about the system that maybe political scientists need to figure out, and that speaks a lot to what Ron is talking about. Doctors, not just as ordinary citizens, but as people who are trusted when they are advocates for health, population health, could have a lot of influence. And I'm wondering if not just doctors, also kind of all clinicians, if we shouldn't, when we educate students, educate them to see as a very big part of their responsibility to be advocates for population health, under the recognition that housing and education and finances and all those things affect health no less than what's going on inside the clinic.
Thank you, Dr. Ayal. I'll just turn to the panelists if you have any reflections on the comments that we have just heard.
No, I definitely agree that population health improvement cannot occur only within the healthcare system. So if I think back to what we were able to do in terms of changing clinical algorithms, that really came from partnering with the City Department of Health. They provided initial funding. They provided us with resources and data that allowed us to do that. And that as educators and those of us who are charged with developing or supporting, rather, our future healthcare leaders, it's creating education outside of the four walls of the institution, which includes partnering with communities. So community-based partners are very vital to our to advancing health equity, because they're not they can say and act without, concerns about what will happen to them, and they can talk politics and advocacy, and they can speak their true emotions, but and providing opportunities for our students to be in those environments are really important for us to really advance. So it's really looking outside of the academic institution and placing healthcare in the community, and leveraging the expertise of the community as well.
Just want to quickly echo that we were recently funded by the Patient-Centered Outcomes Research Institute to conduct a study that actually, at the leadership structure, MPI structure, is with a community-based organization as the MPI with an academic investigator. And the intervention itself is actually integrating social determinant of health screening, but it also uses a volunteer base from the CBO to facilitate warm referrals to the services that are identified through the clinical care settings. And so I think we do have to think about these partnerships in really different ways, even in the delivery of care. How can we integrate the strengths of our community-based partners to facilitate even care delivery in healthcare contexts in new ways? And so in this particular partnership, the Volunteer Corps is trained in behavioral activation, as well as has resources available of the services that are available for particular types of identified social needs. But the combination of behavioral activation with the services that are available that they are keeping abreast of are just service, like it's a partnership that leverages the strength of our respective entities, right? Like this is not a service that could happen easily within a healthcare context, but is integral to the mission of our community-based organization and facilitating redress to the social determinants of health among their community members. So just, I think it's something that really resonated for me, because we're about to embark upon this study, which is really trying to facilitate these types of community-based synergies in clinical care. So, thank you, Dr. Booten.
I'd like to pick up on the point made by Dr. Baer, where it's about a social revolution, and it, ties into what you were saying. I think that we need a tsunami, because we have incredible initiatives and programs, and what you see is they're funded, they do well, they perform well, and then they go away. And that's a problem, right? So sustainability, viability. If you look at, and I've had the privilege of working abroad in a sick fund system or universal payer system, where the underpinning philosophy is primary care, community-based care. And so the programs don't go away, and you see the outcomes then lining up. You have 11% reduction in readmission rates, right? So we have to continue with these initiatives. We have to continue coordinating between professions, between areas, between fields. We have to continue engaging the citizens and the people and the communities. But we need to have societal conversations. What do we value? What are those underlying philosophies and values that translate into the policies and then dictate where the resource and how the resources are implemented?
Once again, picking up on a theme from Dr. Bayer's talk, engines of change serve to perpetuate inequalities, inequities, disparities. And I'm not saying that I'm not adverse to progress. I think progress is extremely important, but it's inherently unequal, and I think there are historically there have been both malevolent forces, but I'm really thinking about those that just seem to be self-perpetuating bias that's so ingrained in a system that we, barely recognize it. It's just a routine part of life, and we even come to accept it in a way. We're challenging it, I mean, it's been challenged in the context of clinical trials. So clinical trials historically, and today really, tend to be homogeneous populations with small percentage of minorities. And, you know, when you apply clinical practice guidelines, you're drawing on those trials, and they may not be equally applicable. I'm not a physician, so I should be careful in drawing strong conclusions, but, you know, they may not be perfectly applicable to all populations. There's a corrective mechanism in place with regards to that. I think NIH, if you're looking to get funded for a clinical trial, you have certain requirements, NIH. I'm less certain of this, but I think journals have expectations that you have a broader base trial and you endeavor to include minority populations and so forth. But I think at a broader societal level, and I'm thinking mostly of the introduction of technology and precision medicine and health information technology are sort of two of the pillars that I'm most concerned about. And I think without a fuller understanding of the dimensions and complexity of those issues, we run the risk of basically exacerbating inequities and disparities.
Great. And I'm going to conclude our panel here. I want to thank each of the panelists for your joining us today and for just a really wonderful and insightful conversation. So thank you each. Yeah, thank you. I'm going to turn it to Dr. Landsman, who's going to provide us with some concluding remarks for our symposium this afternoon. And would just like to personally thank you all for joining us today, myself. Thanks.